So, good afternoon, all. We will start with the rest of the immunosuppressive agents. So, I was just searching for where was that slide with the name of those compounds which I had listed under the other biologics. So, till now we have discussed about the calcineurin pathway inhibitors, and we also discussed about the anti-proliferative agents. So we will have to also discuss about some other agents which are called as biologic agents, which are used for immunosuppression. But one important difference between the other agents like calcineurin pathway inhibitors, the mTOR inhibitors, and the anti-proliferative agents that we have seen as compared to the other biologic agents that we are going to discuss is that the other biologic agents that we are going to review now, those other biological agents, their use is primarily in conditions related to autoimmune disorders rather than for rejection of transplanted grafts. So that is the basic difference. Now in the biologics category, you will know that there is some compound called as TNF alpha, tumor necrosis factor alpha. So this tumor necrosis factor alpha is primarily produced by macrophages. And what is the role of this tumor necrosis factor alpha is inhibiting the cell proliferation and also causing cell death. So that is the function of tumor necrosis factor alpha. So tumor necrosis factor alpha is an important mediator of graft rejection and is also important mediator for several autoimmune conditions. So what happens is whenever the antigen exposure is there, if the macrophage is activated, the macrophage starts to produce TNF alpha, and that TNF alpha goes and injures the endothelium in the grafted tissue. So for example, liver is grafted, kidney is grafted, heart is grafted. Whenever there is a incompatible graft, and if the host responds by forming lot of TNF alpha, the TNF alpha can go and block, can actually kill the endothelial cells in the blood vessels of the grafted organ. And in the grafted organ, when the endothelium of the blood vessel is damaged, there will be clot formation in the endothelium of that blood vessel of the grafted organ, and the grafted organ will undergo ischemic necrosis. So this is what will happen if TNF alpha is produced by the macrophages within the host. So our goal is to stop the production of the TNF alpha. And also TNF alpha is an important mediator of several autoimmune conditions, including rheumatoid arthritis, juvenile rheumatoid arthritis, ankylosing spondylitis, and in some cases even in inflammatory bowel disease, that is ulcerative colitis and Crohn's disease. So TNF alpha plays an important role in cell injury, in rejection of grafts, as well as in those autoimmune conditions like juvenile rheumatoid arthritis, idiopathic arthritis of the juveniles, ankylosing spondylitis, and in patients with inflammatory bowel disease, that is ulcerative colitis and Crohn's disease. So now the goal of treatment with the TNF alpha inhibitors, is it easily achieved without toxicity, or the goal of treatment with TNF alpha inhibitors in protecting the organ that is grafted from suffering injury, or in autoimmune conditions giving the relief, is it associated with significant type of risk of adverse effects? So that is what we will see now. And there are two categories of TNF alpha inhibitors that we have. One category of TNF alpha blockers is that which will only neutralize the circulating TNF alpha. So TNF alpha, whenever it is produced by the macrophages, it enters into the circulation and it is soluble in the plasma and it moves freely. So that type of soluble TNF alpha is bound and neutralized by a particular compound called as etanercept, ETANERCEPT. Etanercept, ETANERCEPT. What is this etanercept? Etanercept is actually a compound which is a receptor for the TNF alpha. So the structure of the drug etanercept is such that it is actually a receptor for TNF alpha. It is not only a receptor for TNF alpha, it is also having Fc portion of immunoglobulin G. So it is actually a receptor coupled to Fc portion of immunoglobulin G. For example, if you imagine the umbrella, the dome of the umbrella, which is formed by the waterproof sheet, that is like the receptor for TNF alpha, and the handle of the umbrella, the stick that people hold on to, is the Fc portion of the IgG. So the structure of etanercept can be considered analogous to that of an umbrella. So the top dome portion of the umbrella is analogous to the receptor for TNF alpha, and the handle of the umbrella corresponds to the Fc portion of the immunoglobulin G. So what happens is, whenever any person is exposed to an antigen, and if the macrophage is stimulated, and if the macrophage has produced TNF alpha, and if the TNF alpha is solubilized in the plasma and is circulating, before it could go and bind to the endothelial surface, before it can go and bind to the neutrophil surface, before it can go and bind to the fibroblast surface, because TNF alpha receptors are there on all these surfaces. It is there on the endothelium, it is there on the neutrophils, and it is there on the fibroblasts. So what happens is, how does the TNF alpha reach these sites? How does the TNF alpha reach to the endothelium? How does the TNF alpha reach to the fibroblast? How does the TNF alpha reach to the neutrophil receptor? Through circulation. So what we do is, when you give this etanercept, ETANERCEPT, I repeat it again, that etanercept is a receptor. So instead of binding to the receptor on the endothelium, instead of binding to the receptor on the neutrophil, instead of binding to the receptor on the fibroblast, now because we have given this drug intravenously or subcutaneously, generally we give TNF alpha blocking drug like etanercept subcutaneously. When you give subcutaneously, it will enter into systemic circulation, and after entering into systemic circulation, this TNF alpha receptor bound to the Fc portion of the IgG will tag or bind to the circulating soluble TNF alpha. So what happens is, the circulating TNF alpha is neutralized within the circulation itself by the etanercept compound that we have given, and the circulating TNF alpha no longer has the ability to bind to endothelium, has no longer the ability to bind to neutrophil, has no longer the ability to bind to fibroblast, because before this could go and bind to the endothelium or the neutrophil or the fibroblast, the TNF alpha receptor that we have given has bound to the circulating TNF alpha. And after binding to the circulating TNF alpha, what does etanercept do? Etanercept, because it is also having the Fc portion of IgG, will take this receptor which is bound to the TNF alpha towards the macrophages and will dump it back in the macrophages. So TNF alpha, from where it came, it goes back there. So it doesn't show any action. So for example, a soldier goes out to hit out at the enemies, but the soldier is captured and put back in his own home and is not able to go to the front of the war where the need of the soldier is there. Obviously you will not get the effect of the soldier, because even before he could go out to the battlefield, we have kidnapped him and we have hijacked him and we have put him back in his home. So similarly, TNF alpha that is produced from the macrophage, which is going to is on the pathway, is circulating, as in on the journey to go and bind to the receptors on the endothelium, on the fibroblast, on the neutrophil. We have sent our TNF alpha receptor along with the Fc portion of the IgG to bind to that TNF alpha which is there in the circulation and neutralize it and take it into the macrophage and deliver it inside the macrophage. So we did not allow the TNF alpha that is produced on the macrophages to bind to the endothelium, to bind to the neutrophil, to bind to the fibroblast, and I hope that is very clear to you how etanercept does not allow the TNF alpha to achieve the goal that it wants to achieve. What is the goal that TNF alpha wants to achieve? TNF alpha wants to bind to the endothelium, bind to the neutrophil, bind to the fibroblast and produce injury. So endothelium injury will lead to clot formation, and the clot formation will lead to rejection of the graft, and neutrophil will lead to inflammation, activation of metalloproteases, collagenases that will cause tissue destruction. So that is valid in case of autoimmune disorders. So in autoimmune disorders, if you allow the TNF alpha to act, TNF alpha will activate neutrophil, neutrophil will activate collagenases and metalloproteases, and they will destroy the tissue matrix. So tissue destruction in autoimmune conditions, for example, the synovium of the joints is destroyed in rheumatoid arthritis, it is destroyed in idiopathic juvenile arthritis, it is destroyed in psoriatic arthritis, it is destroyed in ankylosing spondylitis. Why? Because neutrophils are activated. And what do the neutrophils do? The neutrophils that are activated by the TNF alpha will activate metalloproteinases, collagenases, and that will break down the tissue matrix, and that will lead to degenerative disease. So that is how this rheumatoid arthritis, the idiopathic juvenile arthritis, the ankylosing spondylitis, the psoriatic arthritis, and ankylosing spondylitis, there is tissue degeneration. So that we can stop by giving etanercept. Also remember carefully that if you have given etanercept can neutralize only the TNF alpha that is circulating. If the TNF alpha has already gone and bound to the endothelium, bound to the neutrophil, bound to the fibroblast, then etanercept doesn't really reverse the effect of that type of a bound TNF alpha. Only the free circulating TNF alpha can be neutralized by etanercept. That is an important thing to remember. So you know what is etanercept? It is a TNF alpha receptor. It is bound to Fc portion of IgG. How does it act? It binds to the circulating TNF alpha, and then after binding to it, it takes it into the macrophages, doesn't allow the TNF alpha therefore to act on the endothelium, neutrophil or fibroblast, therefore doesn't allow the organ to be rejected, which is grafted, and doesn't allow the autoimmune condition to worsen. And what are the side effects of this? Etanercept can cause significant immunosuppression, and it may lead to secondary bacterial, viral, fungal infection. Especially risk of tuberculosis is manifold increased in people who take etanercept. So you should be careful. If people already have significant immunocompromised status, people already have diabetes, and people have any other predisposition for development of an infection, then etanercept should not be given, because in normal individual itself it lowers immunity. If a person is already immunocompromised, it will make them even more immunocompromised, and that will affect their ability to defend themselves from bacterial, viral, fungal infections. So they will become susceptible, especially to tuberculosis. The susceptibility is very high after giving TNF alpha blockers. So then there is another compound in the TNF alpha category, TNF alpha blocking category in fact, and that compound is called as infliximab. INFLIXIMAB, infliximab. This, as you know, the name is ending with suffix MAX, therefore it is a monoclonal antibody. MAB is the suffix for monoclonal antibody, infliximab, INFLIXIMAB. And whenever you have the XI in the monoclonal antibody, XI indicates it is a chimeric monoclonal antibody. That is, part of the monoclonal antibody is derived from the mouse and a part of it is derived from the human. So this will cause allergy and hypersensitivity reactions. So infliximab has the ability to cause, in some individuals, allergy, hypersensitivity, and sometimes frank anaphylactic shock. Of course, infliximab is also given subcutaneously. Apart from juvenile rheumatoid arthritis, apart from rheumatoid arthritis in adults, apart from ankylosing spondylitis, apart from using psoriasis, it can also be used in inflammatory bowel disease. So inflammatory bowel disease, the TNF alpha blocker that is used is infliximab. And this infliximab again can lower the immunity and can increase the risk of bacterial, viral and fungal infections in an individual. So if person is immunocompromised, we should not administer infliximab. Then infliximab, how does it differ from etanercept? Both are TNF alpha receptor blockers, is a similarity. Now what is the difference? The difference is that etanercept can only bind and inactivate TNF alpha that is free form in the circulation, whereas TNF alpha that is bound to the surface of the cell, even if it is bound to the receptors on the endothelium or the neutrophil or the fibroblast, that can be bound by infliximab. So infliximab can neutralize the TNF alpha that is bound to the surface of the cells, that is the endothelial cell or the neutrophil or the fibroblast, as well as it can neutralize the freely circulating TNF alpha. That is the advantage of infliximab. And the additional advantage of infliximab is it has been proved to be effective apart from rheumatoid arthritis, apart from psoriasis, apart from ankylosing spondylitis. It can also be used in inflammatory bowel diseases, that is ulcerative colitis and Crohn's disease. So that is about the infliximab. And then next group of drugs in this category of biologic agents that are used in immunosuppression is IL-1 receptor blockers or IL-1 antagonists, interleukin 1. You know, in rheumatoid arthritis, TNF alpha and interleukin 1 play a significant role. Interleukin 1 and TNF alpha are the main mediators of the inflammation that happens in rheumatoid arthritis. So there you can specifically use this drug, interleukin 1 receptor blocker or interleukin 1 antagonist, called as anakinra, ANAKINRA. Anakinra is interleukin 1 receptor blocker, which is used in rheumatoid arthritis. And of course, whenever you use anything that is blocking interleukin 1 or TNF alpha, they will cause some amount of immunosuppression. There may be theoretical increase of bacterial, viral or fungal infections in these individuals. So only two things important about anakinra. Anakinra is an interleukin 1 receptor blocker. It is used in treatment of rheumatoid arthritis, because interleukin 1 is an important mediator of inflammation that happens in rheumatoid arthritis. Then there are interleukin 2 receptor blockers also. We saw that the calcineurin pathway inhibitors, that is cyclosporin, tacrolimus, what do? They reduce the production of interleukin 2, because we know interleukin 2 is one of the important mediators of the immunological cascade. Interleukin 2 is the one that actually stimulates the other lymphocytes to come to the site of inflammation, whether it is due to autoimmune condition or whether it is due to a graft that is there. The recruitment of all these lymphocytes is because of interleukin 2, and not only that, the proliferation and differentiation of the lymphocytes is also because of interleukin 2. So people got an idea, if we cannot stop the production of interleukin 2, can we block the interleukin 2? Because there is a small difference between production inhibitors and blockers. For example, if I have been grafted with a kidney of a donor and somehow I started reacting by forming lot of interleukin 2. At that time, if you give me cyclosporin or tacrolimus, or if you give me sirolimus, which all inhibit interleukin 2 production, I may not get much benefit because interleukin 2 has already been produced significantly. Now what I need is, I need some drugs which will block the effects of interleukin 2. So if some person comes with a reasonably well progressed advanced stage of immunological cascade, where lot of reactions have already happened, antigen has already triggered the T cells to produce lot of interleukin 2, and that interleukin 2 is already on its way to bind and stimulate more and more lymphocytes to create a massive immunological reaction. In such a case, inhibition of production of interleukin 2 may not alone be sufficient. You need to also have a mechanism to block the production or block the action of the produced interleukin 2. So how do we block the actions of produced interleukin 2? So already that which is produced, the interleukin 2, if we have to block, the interleukin 2 receptor blockers that we use are two. Basiliximab, 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 BASILIXIMAB is a interleukin 2 receptor blocker, and there is another compound which is called daclizumab, DACLIZUMAB, daclizumab. It is also an interleukin 2 receptor blocker. So these are monoclonal antibodies, as you see from the name itself. One is basiliximab, other is daclizumab. They all end with the suffix MAB, monoclonal antibody. So both are monoclonal antibody. What is the advantage of monoclonal antibody? The advantage of monoclonal antibodies is monoclonal antibodies are highly specific for the target that they are going to attach and bind. So when you give these monoclonal antibodies like basiliximab and daclizumab, they are highly specific. They specifically seek out the interleukin 2 receptor and bind to it and do not allow the binding of the interleukin 2 to the receptor. So we have made the interleukin 2 receptor to be preoccupied by either basiliximab or daclizumab, so that no new interleukin 2 molecule can come and bind to it. The space has already been occupied on the receptor by the monoclonal antibody that we are giving. So IL-2 specific monoclonal antibodies like basiliximab and daclizumab can be used even when there is an ongoing graft rejection, or when the conventional therapy in terms of suppressing the interleukin 2 in case of some people with autoimmune disorders is not able to give adequate results. Then you can give interleukin 2 receptor blockers. So basiliximab and daclizumab have that type of a clinical relevance. The question can be framed very simply and easily here, saying that a patient who was grafted with a donor organ was given cyclosporin, tacrolimus or sirolimus, but still the patient had developed ongoing graft rejection. Now what should be done? Should we increase the dose of cyclosporin, tacrolimus, sirolimus, or should we give basiliximab or daclizumab? The answer is preferably give basiliximab or daclizumab, because once the interleukin has been started, and if the interleukin has already been produced significantly, which was not possible to be stopped adequately by giving either cyclosporin or tacrolimus or sirolimus, it may not be worthwhile to try giving larger dose of cyclosporin or tacrolimus or sirolimus, because already lot of interleukin 2 might still be produced despite we having given either cyclosporin or tacrolimus or sirolimus. So the best way is to block the interleukin 2 receptor, and that can be done with basiliximab and daclizumab. What I am trying to emphasize here is that the goal is really to neutralize the effects of interleukin 2, but that can be done in two ways. One is inhibit the synthesis of interleukin 2, which is the mechanism of action of cyclosporin, tacrolimus and sirolimus. On the other hand, the other way which you can minimize the effects of interleukin 2 is block the receptors of interleukin 2, and the blocking of the receptors of interleukin 2 very effectively, efficaciously we can do with basiliximab and daclizumab, which bind to no other protein in our body but specifically go and bind only to the interleukin 2 receptor on the surface of the T cell. That is the advantage. They are highly targeted drugs. Now, what is the difference between basiliximab and daclizumab? Basiliximab, if you see the name itself, BASILIXI, XI whenever it is there, it is a chimeric monoclonal antibody. That is, a part of it is murine, that is mouse derived, and a part of it is human protein derived. So again, there is risk of allergy, hypersensitivity and anaphylaxis with this. Whereas daclizumab, if you see DACLI-ZUMAB, daclizumab is a humanized monoclonal antibody. So the major portion and the minor portion, both of them are derived from the human protein. So therefore, the risk of allergy, hypersensitivity, anaphylaxis is low with daclizumab. So if you have to choose between basiliximab and daclizumab, always people choose daclizumab because the risk of adverse effects is low with daclizumab. Apart from that, there is one more difference. Pharmacokinetic difference is there between basiliximab and daclizumab. Basiliximab has to be given once in a week, whereas daclizumab can be given once in 3 weeks. So that is even more comfortable. So the subcutaneous injection that you have to give, if you have to give it at less frequent intervals of time, better is to give daclizumab. Daclizumab can be given just once in 3 weeks, whereas basiliximab has to be given once in a week. So that way you will reduce the number of injections that the patient receives if you give daclizumab. More injections need to be given if you have to give basiliximab. So that is the advantage of using daclizumab over basiliximab. One is adverse effects will be low. The next is the number of injections will be low with daclizumab as compared to basiliximab. So that is about the interleukin 2 receptor blockers. And then there is this interleukin 2 receptor blockers. Monoclonal antibodies are also called as anti-CD25 antibodies. The other name for these compounds is anti-CD25 antibodies. So what happens is the CD25 protein structure is very similar to the interleukin 2 structure. So basically these are those which block the CD25 receptor. Interleukin 2 receptor is also called as CD25. So therefore CD25 receptor blocking antibodies are the same as interleukin 2 receptor blocking antibodies. Next is what we go to the other compound. It is not used very commonly, but it is of historical interest, and why it is not used commonly also important for us to know. So that is why we need to discuss that other compound. It is called muromonab, M-U-R-O-M-O-N-A-B, muromonab, M-U-R-O-M-O-N-A-B, muromonab. It is also a monoclonal antibody, as you can see from the name. And this monoclonal antibody muromonab is a CD3 receptor blocking antibody. CD3 receptor blocking antibody. Where is the CD3 receptor present and what is the function of the CD3 receptor? Now you imagine a normal lymphocyte, and in the normal lymphocyte you have a T cell receptor, and beside the T cell receptor you have the CD3 receptor. What is the function of the T cell receptor? In the morning I was mentioning to you that if it is a CD4 lymphocyte, the CD4 lymphocyte will get the antigen, recognize the antigen only when it is presented by the antigen presenting cell in combination with MHC2. Similarly, CD8 lymphocyte will recognize and accept the antigen only from an antigen presenting cell if it is coming through MHC1. So whenever the antigen presenting cell brings the antigen, the lymphocyte has to have some site on its surface which recognizes that antigen that is being presented, and that site is the T cell receptor. But the T cell receptor is assisted in its function of recognizing the antigen by another complementary protein which is there on the T lymphocyte, that is called CD3 antigen. So CD3 antigen is also there on the T lymphocyte, and it is there beside the T cell receptor. What is the function of the T cell receptor? To accept the antigen being presented by the antigen presenting cell. So is it enough if the T cell receptor receives the antigen, or it requires the help of some other protein on its surface? It requires the help of some other protein on its surface. The other protein that is there on the surface of the T lymphocyte is called the CD3 antigen. What is the role of the CD3 antigen? Is CD3 antigen facilitates the binding of the antigen presented by the antigen presenting cell to the T cell receptor which is present on the surface of the T lymphocyte. Now what we do is we make an antibody called muromonab. The muromonab is a CD3 monoclonal antibody, So when you give this, it will go and bind to the CD3 protein or the CD3 receptor on the surface of the T lymphocyte. When this happens, what happens is, even though the antigen presenting cell presents the antigen to the T lymphocyte, and the T lymphocyte's T cell receptor picks up this antigen, it will not be able to process that antigen because you have blocked the CD3 antigen which is there on the surface of the T lymphocyte. So always remember that the T lymphocyte always requires not only the T cell receptor to recognize the antigen, it also requires the help and support of another protein called as the CD3 antigen or the CD3 protein which is there on its surface. If you block the CD3 protein, even though the antigen presenting cell presents the antigen, the T cell will not be able to process the antigen, will not be able to mount a immunological response. So that is what is done by CD3 blockers, that is Muromonab. But one thing is there, the body sometimes respond very vigorously and very violently to the blocking of the CD3 receptor. So whenever Muromonab is given, there has been massive cytokine release, and that massive cytokine release has led to diminished use of this drug called Muromonab, and that massive cytokine release could be so life threatening, it can cause respiratory distress syndrome, shock, and the person may die. In fact, the whole range of symptomatology that you see that is produced by Muromonab whenever it is given intravenously is very frightening. It can cause fever, headache, chills, rigors, meningitis, therefore seizures may happen, and it can lead to hepatic dysfunction, it can lead to renal dysfunction, it can lead to increased vascular permeability and shock. So these are all the manifestations. It can lead to respiratory distress syndrome. So these are all the things that will happen very dramatically within a very short span of time if Muromonab is administered. So this is one of the important problems with Muromonab. Therefore, we do not use Muromonab any longer. Muromonab only indicated when you have tried all other means of immunosuppression and they have all failed and they have not been able to produce you the required benefit. Then Muromonab can be used as a reserve option when all other immunosuppressive agents have been suboptimal in the expected benefit that is aimed at. Then Muromonab, can we prevent to some extent this type of a massive cytokine release that it can produce as a side effect? If you premedicate the person with the corticosteroids like dexamethasone or prednisolone or methylprednisolone, the probability of the violent cytokine storm that happens with Muromonab can be reduced. So always, most of the time, whenever you have someone who is eligible to receive Muromonab, what do I mean by eligible to receive Muromonab? Anyone eligible to receive Muromonab is someone who has not been adequately immunosuppressed with whatever medications we have. In that case, we have no option but to go to seek the refuge of Muromonab and say, you are the only drug that we are now looking up to show the pharmacological action. But before that, give corticosteroid. Then the probability of having a cytokine storm will be far more lower, and then the patient may be able to tolerate Muromonab without developing fever, chills, rigors, hepatic dysfunction, then seizures, hypotension, shock, myocardial depression, and respiratory distress. Those will not develop, or the probability at least is less if you premedicate someone who is about to receive Muromonab with the corticosteroid. So that is about Muromonab. Then the other drugs which are equally important in immunosuppression which we use are those which are derived from certain animals or from humans, and they are used therapeutically. For example, we use anti-thymocyte globulin or anti-thymocyte serum. Anti-thymocyte serum or anti-thymocyte globulin is a polyclonal antibody. It is not a monoclonal antibody, it's a polyclonal antibody, because whatever antibodies will be produced against the thymocyte will not come from only one clone of cells, it will come from tremendously different clones of cells. So polyclonal antibodies or anti-thymocyte serum or anti-thymocyte globulin is one and the same. So anti-thymocyte globulin or anti-thymocyte serum, ATS we call it. So what is this compound? How do we get it? What we do is we take the human thymocyte and we inject it into the horse, and the horse will then react very violently to this thymocyte and produce lot of antibodies against the thymocytes, and this we can take by bleeding the animal, separating the plasma, filtering out the antibodies, lyophilizing it, that is making it in the form of a powder and packing it into vials and making it available for administration to people. So this is anti-thymocyte globulin. This antithymocyte globulin or antithymocyte serum is obtained from sera of animals, and these animals have been previously sensitized to the human thymocyte antigens. So when you give these antibodies that are obtained from the animals, because the animal proteins also invariably will be added to this preparation, there is very high risk of allergy, hypersensitivity and anaphylaxis. That is the big problem with this. However, if you can premedicate with antihistaminics and premedicate with corticosteroids, the probability of allergy and hypersensitivity will be lower. And will it be very significant immunosuppression that you get, or with the mild immunosuppression that you get? It will be really good immunosuppression that you get, because the thymocytes will be the T lymphocytes and the CD4 and CD8 subsets of the T lymphocytes. So those T lymphocytes will significantly be totally removed from circulation. It will be almost zero circulating T lymphocytes in the individual who receives this antithymocyte globulin. For example, if I am the patient and if I have myasthenia gravis and someone wants to treat me with antithymocyte globulin, the moment they give me antithymocyte globulin, the antithymocyte globulin will go into my circulation and will remove all my thymocytes. So the thymocytes that are there in my circulation, which are responsible for my autoimmunity, they will all be suddenly removed and rendered inactive by this antithymocyte globulin. So significant and powerful immunosuppression can be obtained with it. But one thing is, we should remember that because the animal source of this antibody, it can lead to significant intolerance and cause allergy, hypersensitivity and anaphylaxis type of a manifestation. It is not really very widely used unless and until someone is having a very frank, gross organ rejection. You have tried corticosteroids, you have tried interleukin 2 receptor blockers, you have already given them calcineurin pathway inhibitors, you have given mycophenolate mofetil, and still the organ is not being salvaged, the organ is not being saved, and it is continuing to show rejection. The immunological response of the host is not relenting. It is mounting an immunological response which is increasing with time and destroying the transplanted organ. In that case, you can give antithymocyte globulin. That antithymocyte globulin will go and remove all the circulating thymocytes, and then the patient will have a dramatic lowering of the immunological activity, and that may help in salvaging the transplanted organ. So that is about antithymocyte globulin. Then there is another important compound called as anti-D. Anti-D globulin or anti-RH immune globulin. Anti-RH immune globulin. It is also called as anti-D. Anti-RH immunoglobulin is very much relevant, especially, for example, there is a case where there is a couple and the husband is RH positive, wife is RH negative, and the fetus happens to be RH positive, and if this is the first pregnancy. So if it is the first pregnancy, if the fetus is RH positive and the mother is RH negative, what happens is during the time of delivery, the fetal RBC will enter into the maternal circulation. The fetal RBC will enter into the maternal circulation. When the fetal RBC enter into the maternal circulation, the mother is RH negative and the fetal blood now carries the RH positive antigen. And this RH positive antigen from the fetus that has entered into the mother will trigger antibody formation in the mother. So nothing happens to the mother at that time. But if a second pregnancy also, there is a child or a fetus and that fetus is RH positive, then the antibodies that are formed in the mother during her first pregnancy, those antibodies are IgG in nature, and those IgG antibodies will cross over across the placenta into the fetus that is developing during the second pregnancy and will cause hemolytic disease of the newborn or erythroblastosis fetalis. It will lead to abortion because of the death of the developing fetus. So what happens is, if a mother who is RH negative or a pregnant woman who is RH negative has had history of a RH positive delivery previously, immediately within 72 hours of such a delivery, the mother has to be given anti-RH antibodies, that is anti-D immunoglobulin or anti-RH immunoglobulin. This will be something which will help in preventing the mother from getting exposed to the RH antigen of the fetus. And if the mother's immunological system is not exposed to the RH antigen coming from the fetus, then the mother will not be sensitized, the mother will not develop antibodies. So even if subsequent pregnancy RH positive fetus is developing, then the mother will not reject that fetus because it has not been previously sensitized. The mother's immunological system has not been previously sensitized. I hope you understand this. I will just simplify it further. If a growing fetus in first pregnancy of a woman is Rh positive, and if the woman is Rh negative, what happens is during delivery the Rh positive antigens on the RBC from the fetus cross over into the mother, and the mother's immunological system will recognize these Rh positive antigens, and because the mother is herself Rh negative, this Rh positive will be foreign antigens for her, and she will develop a memory for the Rh antigen, and then she will start producing Rh antibodies. So subsequent pregnancy also, unfortunately, if it happens to be Rh positive pregnancy, then during the pregnancy itself, the mother's antibodies that are there, which are IgG in nature, they will cross the placenta and destroy the fetus, and that will lead to erythroblastosis fetalis or hemolytic disease in the newborn. So that is what is to be prevented by giving a dose of anti-D immunoglobulin, which is anti-Rh immunoglobulin, to a woman who has recently delivered Rh positive child and whose blood group is Rh negative. If the mother is Rh positive and if it develops Rh negative child or Rh positive child, we don't have any problem. But if the mother is Rh negative and she has history of delivering a Rh positive child, within 72 hours of delivery, it is better to give her 1000 to 2000 micrograms of anti-D immunoglobulin, so that the subsequent pregnancy there won't be any risk of hemolytic disease of the newborn or erythroblastosis fetalis. So that is the important perspective of treatment with the anti-D immunoglobulin or anti-Rh globulin. Of course, even if a Rh negative mother has an abortion, within 72 hours of the abortion, about 100 micrograms to 1000 micrograms of this immunoglobulin has to be given to the mother, so that if a subsequent pregnancy Rh positive child develops or fetus develops, then there won't be any rejection. So why we are giving the anti-D immunoglobulin, anti-Rh immunoglobulin to a mother who has already delivered a Rh positive child and who herself is Rh negative? Why are we giving it? It is not for that particular pregnancy, it is for the subsequent pregnancies, to prevent the maternal antibodies from crossing over into the fetus and destroying the fetus even before it could be born. So that is the advantage of first 72 hours giving the antibodies whenever a Rh negative mother is having history of having aborted or delivered a Rh positive child. So that is about this Rh immunoglobulin anti-D. This is very important, very crucial, because this is part of routine practice in our obstetrics department, where if Rh negative woman is there and if she has history of abortion or if she has history of delivery of a Rh positive child, then she will be given within 72 hours. And how does this work? How does this work is two mechanisms. When you give this Rh immunoglobulin, how does it work? It works by coating the surface of the circulating fetal RBC. So within 72 hours you are giving. So the fetal RBC, which have a Rh antigen on its surface, when they are flowing in the mother's blood, whatever immunoglobulin that you have given, that anti-D immunoglobulin, anti-Rh immunoglobulin, that will go and bind to the surface of the fetal RBC, and the fetal RBC antigen, that is the Rh antigen, will not be allowed to get exposed to the maternal immunological system. So the maternal immunological system is shielded from the antigenic exposure of the fetus, and therefore the maternal immunological system will not know to produce antibodies, but that only if it is given within 72 hours. If you give the Rh immunoglobulin or anti-D injection after 72 hours, the fetal RBC would have nicely got sensitized to the mother's immunological system. Mother's immunological system must have been sensitized. It would have got lot of memory cells, and then subsequently whenever there is a second pregnancy, those antibodies can actually cross the placenta and injure the fetus. Another thing is, there is something called as isoimmunity. What is this isoimmunity? Is IgG especially has the potential to suppress the production of its similar structure proteins. So for example, if this woman who is Rh negative has the spillage of the Rh positive blood from the fetus into her blood, and some RBC have started sensitizing her immunological system, in such a case, when you give this immunoglobulin G, that is anti-D or anti-Rh immunoglobulin, This immunoglobulin not only coats the surface of the remaining RBC and prevents further exposure of the RBC to the maternal immunological system, this IgG independently has also got the capacity to suppress the mother's immunological system so that it doesn't produce the IgG. Actually, IgG when given to people suppresses further production of IgG. This is called isoimmunity. So that is the reason why we give IgG. IgG here has two roles. It not only coats the surface of the fetal RBC and doesn't allow the fetal RBC to get exposed to the maternal immunological system. This IgG that we are giving can actually suppress the production of further IgG, and that is how both ways we get the advantage of the mother not having much immunological response to whatever RBC are exposed. So that is about the anti-D immunoglobulin. So immunosuppressive agents is what now comprehensively I have told you. Maybe I will just do in the next 5 minutes a quick review. There are calcineurin inhibitors, in that you have cyclosporin and tacrolimus. Cyclosporin is basically nephrotoxic. Apart from that, it can cause hyperuricemia, it can cause hyperglycemia, yes, because of diabetes risk, it can cause hyperkalemia. Do not combine cyclosporin with compounds that are nephrotoxic like amphotericin B, like NSAIDs, vancomycin, aminoglycosides. Cyclosporin long term we don't use because it can cause nephrotoxicity, and if it is a grafted kidney we use for 1 to 2 months and then shift over to other drugs, because this cyclosporin itself can injure the transplanted kidney. Cyclosporin requires bile for its absorption, so therefore in people who need a liver transplantation, cyclosporin may or may not be an ideal good drug, because if the person is supposed to get a liver transplant, what does that mean? That means that the person is having some liver disease and he is not able to produce enough bile. And if you are giving cyclosporin and cyclosporin requires bile for its absorption, there is no way that bile is going to be really there in the people who are waiting for a liver transplantation. So cyclosporin will not be really an ideal drug to be used for preventing graft rejection of a liver. So the alternative is tacrolimus, because tacrolimus, the extent of its dependence on bile for its absorption is very low. So because of this critical difference between tacrolimus and cyclosporin, whenever a liver transplantation is to be done, tacrolimus is preferable over cyclosporin. Why it is preferable is because tacrolimus doesn't really require much of bile for its absorption. And then of course both tacrolimus and this one cyclosporin are metabolized by CYP3A4. Drug interactions are there, so we should be very careful about the drug interactions. CYP3A4 inducers like phenobarbital, rifampicin, phenytoin will accelerate the metabolism and therefore lower their therapeutic effect, whereas drugs like erythromycin, ketoconazole, they may actually inhibit the metabolism and elevate these drugs and cause significant immunosuppression. Then we had the side effects like tacrolimus having more of neurotoxicity, diarrhea, alopecia and diabetes. So alopecia, neurotoxic, diarrhea, diabetes significantly there with the tacrolimus. Of course nephrotoxicity is as good as that of cyclosporin. The only thing is that gum hyperplasia and then hypertrichosis, that is hirsutism, and hyperuricemia and hyperkalemia little less with tacrolimus. And because we did not want nephrotoxicity, we tried to make another drug called sirolimus. Sirolimus acts through the MTOR pathway. By inhibiting the MTOR pathway, it indirectly inhibits the activation of cyclin dependent kinases which regulate cell proliferation, especially in the T cells and B cells. So sirolimus will therefore, especially T cells here, inhibit the activation of T cells, and the proliferation of T cells is not there. So that is how sirolimus works. Big advantage of sirolimus is not nephrotoxic, can be safely used in preventing graft rejection of a transplanted kidney, but it should never be used in liver disease, because for liver transplantation, because sirolimus is hepatotoxic. Not only hepatotoxic, it is also pulmotoxic. Pulmonary toxicity is also there for this. It also can cause hypertriglyceridemia, it can also cause diabetes, but of course the hirsutism and the hyperuricemia and the hyperkalemia part and the gum hyperplasia is not there with the sirolimus. Then we got to the cytotoxic drugs. In that we discussed mycophenolate mofetil. Most important dose limiting side effect of mycophenolate mofetil was diarrhea and bone marrow depression, and mycophenolate mofetil inhibits both T and B lymphocytes. Mycophenolate mofetil is a inosine monophosphate dehydrogenase inhibitor, and it can be combined with sirolimus and corticosteroids. So then what is the other drugs that we have in the anti-proliferative or cytotoxic category? Like azathioprine we had, and then we had cyclophosphamide, we had methotrexate, and we had chlorambucil. Later, what we discussed in the afternoon, I started off with TNF alpha blockers, that is etanercept, which is a TNF alpha receptor which is bound to Fc portion of IgG. It can bind to the circulating TNF alpha and not allow the TNF alpha to go and bind to the neutrophils, endothelium, or the fibroblasts. Therefore, this can to some extent neutralize the effect of circulating TNF alpha. Important use is in rheumatoid arthritis, important use is in idiopathic juvenile rheumatoid arthritis, another use is in ankylosing spondylitis, and of course in psoriasis also this can be used. Then we discussed about infliximab. Infliximab is a monoclonal antibody, chimeric in nature, can cause allergy and hypersensitivity. It can bind to not only the circulating one, the TNF alpha, but also the one that is bound to the surface of the endothelium or the neutrophil or the fibroblast. Infliximab, in addition to being used in rheumatoid arthritis, in addition to be used in psoriasis, in addition to be used in idiopathic juvenile arthritis, in addition to being used in ankylosing spondylitis, can also be used in inflammatory bowel disease. That is the importance of infliximab. Then we moved to the interleukin 1 receptor blocker. In that interleukin 1 receptor blocker, we discussed about anakinra, and it is used in rheumatoid arthritis. Then we discussed about interleukin 2 receptor blockers, which are also called as CD25 blockers, and these interleukin 2 receptor blockers will work even if the cyclosporin or the tacrolimus or the sirolimus didn't work, because they don't inhibit the production of interleukin 2, but they actually block the action of interleukin 2 by inhibiting the access of the receptor to interleukin 2, because they sit on the receptor of interleukin 2 and block the receptor. So this we have basiliximab and daclizumab, both are monoclonal antibodies. Basiliximab is a chimeric monoclonal antibody, mouse derived portion is also there in it, so allergy hypersensitivity is more. Daclizumab is human, so daclizumab has less side effects, and also kinetically there is a difference in both of them. Basiliximab has a 1 week duration of action, whereas daclizumab has 3 weeks duration of action. So less number of pricks, less frequent administration is required for daclizumab, so that is more preferred. Then we went to the other drug, that is CD3 receptor blocker, because normally when the antigen presenting cell brings an antigen, the T cell receptor takes the antigen, but it is not enough. The T cell receptor is actually helped by another T cell protein called as CD3, but if you block the CD3, even though the antigen presenting cell presents the antigen to the T lymphocyte, the T lymphocyte will not get activated because you have blocked the CD3, and the drug in that CD3 category, which is a blocker, CD3 blocker, is muromonab. The problem is with the cytokine storm that happens with this, so pre-medicate with the corticosteroids to prevent that. And what will be the manifestations of the cytokine storm? Massive fever, chills, rigors, then seizures, then hypotension, then meningitis, respiratory distress syndrome. Those are the manifestations of it. So do you use it commonly? No. Where do you use it? We use it only when all other immunosuppressive agents have been tried and still there is an ongoing type of rejection. And then we discussed about the antithymocyte globulin, which we obtain by injecting the thymocytes into an animal, that is the horse, and then take the antibodies from there and give to the human. It is used in autoimmune conditions like possibly myasthenia gravis, and also when the graft rejection is happening and nothing else works. This works. The problem is because the horse proteins associated with the antibody may be there and it is not human derived, lot of allergy hypersensitivity and anaphylaxis risk. Prevent it by giving pre-medication with either H1, H2 receptor blockers and also corticosteroids. Then we went to the human immunoglobulin, that is immunoglobulin and immunoglobulin against the Rh antigen, that is the anti-D or anti-Rh immunoglobulin. And the most important reason why we give it is when an Rh negative woman develops a Rh positive pregnancy. At that pregnancy nothing happens, but during delivery the RBC can cross over into the mother's immunological system gets activated, and that will lead to second pregnancy failing. So for that, what we do is immediately after abortion or delivery in a Rh negative woman with a Rh positive type of a fetus, we give this Rh immunoglobulin, that is anti-D or anti-Rh immunoglobulin, and that acts by two mechanisms. Coats the surface of the RBC. This has to be given within 72 hours of the abortion or within 72 hours of the delivery. And what does it do? This coats the surface of the RBC and doesn't allow it to expose to the maternal immunological system. The maternal immunological system doesn't get sensitized, and therefore subsequent pregnancy is saved. The other mechanism is immunoglobulin G especially has got the ability to suppress immunoglobulins of the same class. This is called isoimmunity. So if you give immunoglobulin, what happens is the immunoglobulin production itself dips in the mother. So she will not be able to get sensitized to any antigen that is there in the form of the Rh positive RBC from the fetus. So this is what is about the immunosuppressive agents. Now there are three important terms that you need to understand. Hyperacute rejection or accelerated rejection. No drug in the world can save it. hyperacute rejection or accelerated rejection is something which develops in hours. Within hours to a few days, the rejection of the transplanted organ develops. And most importantly, what happens is again the TNF alpha or something like that will be produced. The TNF alpha goes and binds to a neutrophil and to endothelium and to fibroblast, injures the endothelium, clots are formed, the graft gets rejected. The graft dies due to lack of blood supply. So that is the problem with hyperacute rejection or accelerated rejection. It is an antibody mediated rejection primarily, not cell mediated immunity, it is antibody mediated immunity. So graft rejection happens in that way, hyperacute and accelerated, we can't protect it. If it is gone, it is gone. So if hyperacute rejection happens or if accelerated happens, no drug that we have discussed till now works. So whatever we have discussed work only when it is a acute rejection or if it is a chronic rejection, not for the hyperacute or accelerated. So what is acute rejection? Acute rejection is something which starts between 2 to 12 weeks. So within 2 to 12 weeks of a transplanted organ, if the body starts to respond immunologically and reject that organ, slow process, that is called acute rejection. And after 12 weeks, whatever slow process of rejection of the transplanted organ is there, that is called chronic rejection. Most grafts usually get rejected in the first 6 months. If someone survives the first 6 months, then the requirement of immunosuppressive subsequently will be very low, because the probability of grafts getting rejected after 6 months progressively falls. The longer the duration since the transplant survival, then the lower will be the risk of rejection of the graft. So acute rejection, if it is happening, what we can do? Acute rejection, that is something which is happening between 2 to 12 weeks. If it is happening, the best thing is corticosteroid, gold standard. Methylprednisolone is given 1 gram to 1.5 gram IV for 3 to 5 days, and that will suppress the immunity like anything, and that will actually save the graft from being rejected. So if acute graft rejection happens, corticosteroid is good. But if alone corticosteroid is not helpful, along with corticosteroid generally we use either sirolimus or tacrolimus or cyclosporine, and one of the things like mycophenolate mofetil. So you can use mycophenolate mofetil plus sirolimus plus glucocorticoid. Why I am telling this mycophenolate mofetil plus sirolimus plus glucocorticoid combination specifically is because of kidney transplantation. This is a safe regime, because if you see mycophenolate mofetil, no kidney toxicity, it causes only diarrhea and bone marrow depression. If you see at sirolimus is not nephrotoxic, so it is safe. And if you see at glucocorticoid not nephrotoxic. So if a kidney transplant patient is there and if there is a threat of acute rejection, and if acute you are seeing that it's probably happening, the combination that you can give is MSG, that is mycophenolate mofetil plus sirolimus plus glucocorticoid. Other thing is, of course, if it is an acute rejection, you can see that it is happening very fast within the first 2 to 12 weeks. Then immediately methylprednisolone you can start, and then of course you can complement it with the mycophenolate mofetil and the sirolimus. And if it is a chronic rejection, then of course any one of them. If it is renal, again MSG, that is mycophenolate mofetil, sirolimus and glucocorticoid. If it is a liver, you cannot use sirolimus. For liver transplant, you can use mycophenolate plus cyclosporine or tacrolimus plus glucocorticoid. So the only difference is between liver and kidney transplant. If it is a liver transplant, don't use sirolimus. If it is a kidney transplant, don't use cyclosporine or tacrolimus. That is the only thing. Otherwise, mycophenolate mofetil and glucocorticoid remain common to both liver transplant or kidney transplant. If it is a liver transplant, don't use sirolimus. If it is a kidney transplant, don't use cyclosporine or tacrolimus. So that is what is the thing that you need to know. So I think that completes about the immunosuppressive drugs. There is one drug that people may ask, immunostimulant. That immunostimulant, I think BCG if you know, and there is another drug called levamisole, you know. I think that is more than sufficient. So that part really may not be very much required for you. The BCG as an immunostimulant, just one passing reference I will make. You can also look up on levamisole. The BCG part immunostimulant, where it is used. It is used in bladder cancer. So Bacillus calmette-guerin preparation can be instilled into the bladder in people with bladder cancer, and then it will activate the natural killer cells and the lymphocytes, which will take care of the malignancy. So in bladder cancer, we can use this immunostimulant BCG. So immunosuppressants, I have told in detail about all those drugs, starting from the calcineurin inhibitors, the mTOR pathway inhibitors, the antiproliferative cytotoxic drugs, then the biologic agents, that is TNF alpha blockers, then the interleukin 1 blocker, interleukin 2 blockers, then the CD3 receptor blocker, then the antithymocyte globulin and the anti-D immune globulin, and how they are used, and what is hyperacute rejection or accelerated rejection for which we can't do anything, what is acute rejection for which you can give methylprednisolone 1 gram daily 3 to 5 days and you can save the organ from getting rejected. And then if it is an acute rejection, you can use corticosteroids along with other compounds. If it's a liver, use cyclosporine or tacrolimus with mycophenolate mofetil and glucocorticoid. If it is a kidney, then you can use mycophenolate mofetil, sirolimus and glucocorticoid. So finally remember, sirolimus is not nephrotoxic, whereas cyclosporine and tacrolimus are nephrotoxic, and glucocorticoids are the saviors in acute graft rejection. And always remember that mostly some people may require, after the graft being put transplanted, lifelong immunosuppression. Only thing is the dose may keep on coming lower and lower. And of course, if someone asks about these compounds that we use, you can always tell that these compounds are used in autoimmune conditions and graft rejection, and also for sensitization of the mother to be prevented. The anti-D immunoglobulin can be used if the mother is Rh negative and the first delivery of the fetus or the abortion is Rh positive. So that much if you know, I think that solves the requirement of our examinations, theory, viva, entrance for immunosuppressants. And one thing I would also like to express is that the whole syllabus in the pharmacology is now complete. So the classes, I think, are all completed. The whole thing is complete. So 1.5 years of your patient listening, I appreciate and thank all of you for very diligently listening to all that we offer in terms of discussion. A lot of time, unfortunately, it was online. So we tried our best to make it as much as possible interesting and understandable online. It is very difficult looking at the blank monitor and screen and delivering the lecture without knowing what is happening to the understanding of the students. But still, that was what best we could manage. And if you have any things that need to be covered, anything need to be discussed, please let us know. I will be very happy to come back again online and discuss whatever topics from first chapter to last chapter. If anything is not very clear and if you would like to have a discussion on that for me to come online and explain, I will be very happy. Try to pass it on through any one of you or through your CRs, and I will take it up from there in the best possible way that I can. So formally, the lectures in pharmacology have been completed as per the syllabus that is laid out to you. And if any other thing you would like to discuss, as I have already mentioned, you are most welcome to communicate to us, and we will get back to you with whatever topic may be of interest to you.